Good afternoon. I'm Carlo Patrono, Deputy Editor of the European Heart Journal. And on behalf of the Editor-in-Chief, Professor Filippo Crea, I'd like to welcome you to this dialogue with Professor Kazem Rahimi from the University of Oxford, coordinator of the Blood Pressure Lowering Treatment Trialists collaboration. Two top reviewers of the journal will also join this dialogue. That is Professor Franz Messerli from Bern and Professor Luis Ruilope from Madrid, two leading experts in the field of hypertension. And at this stage, I'll turn over the chair to Professor Massimo Volpe, Associate Editor of the European Heart Journal, for the weekly journal scan section. And Massimo is of international renown in the field of hypertension as well. Massimo, please.
Thank you very much, Carlo, and thank to the journal and to the editor-in-chief for involving me in this very interesting dialogue. It's a real honor. I just say hello to Franz and Luis, who accepted to be with us today, but our guest today is Kazem Rahimi. Kazem is a professor of cardiovascular medicine and population health at the University of Oxford and consultant cardiology at the Oxford University Hospital NHS Trust. And he has been one of the leaders and currently leads the blood pressure lowering treatment trialist collaboration efforts. And so welcome, Kazem, today. It's a great honor to have it with you, to be with you today. And I'm sure this will be a very interesting and stimulating dialogue. Just to make a better knowledge, could you introduce yourself and your personal history and maybe some remarks on how you enter the BPLTT group?
Thank you, Massimo, and everyone else for organizing this and for inviting me. I have to say the honor is entirely on my side. I'm so really grateful to be here. Before I say anything about how I got to this place, and like you, I struggled with the acronym BPLTTC, Blood Pressure Lowering Treatment Trialist Collaboration, for some time until I got used to it. But before I got into the sort of the path on how I got to this place, I'd like to first thank really the participants in the clinical trials, which we tend to sometimes forget about. I mean, blood pressure is one of the areas that has been most widely researched. And there have been over 500,000 individuals who have given consent to participate into those clinical trials for several years, taking a dummy pill or an active ingredient or in an intervention, not knowing whether that would be of a net value to them. And for those of us who have been involved in running clinical trials, you know how much of an immense achievement that is, and what sort of altruistic attitude it requires from participants to just take part in those studies. So, and that is really thanks to those people who have contributed the time, taking part in those studies, that we know a bit more about blood pressure management. Now about myself, like many people, getting to where I'm today is mostly due to luck than anything else. I went to medical school in Leipzig in Germany, and really due to chance, I got interested ended up working at the Heart Center in Leipzig, at that time under the leadership of Professor Schuler. And that really laid the foundation for my future career. I mean, Professor Schuler is now retired, but I used to work with people that everyone probably knows in the audience, Holger Thiele, Gerd Hendricks, and others who were in Leipzig. And that was quite a nice environment of aiming to achieve clinical excellence, but at the same time, being close to academia. I mean, I got involved in some of the clinical trials that we were doing there with Holger Thiele and others. But I think that what I enjoyed in that culture was our weekly journal clubs that we had, where a lot was happening. I mean, the scientific community cardiovascular area is so active. The clinical trials coming from various groups, and we were discussing it, and some of them would immediately translate into change in clinical practice. I mean, we had studies at that time about AF control. We had drug-eluting stents coming on. We had the anticoagulants, intervention, non-intervention, and so on. And that was quite, for a young cardiologist like me, you see immediately the impact of research. So I ended up working there a few years. But then one of the things that I personally didn't like about the German training system at that time was that it didn't have the structure to support if you like, broad-based clinical training. So you could have ended up doing just interventional cardiology very early on. And I decided to step back a bit and applied for a position in London to just do general medical training, leaving cardiology out. And that was a new challenge for a couple of years. And going into a new field and going into hematology, I felt I'm back to school. I didn't understand anything what we were talking at the MDTs in the morning. After that, the question came back, what to do next. And speaking to many people, it was clear that in order to achieve maximum impact on clinical practice and policy, you would need to do high quality studies. And many people pointed the finger towards Oxford. And there was a position coming up to work on clinical trials at the Oxford's Clinical Trial Service Unit, now called Nuffield Department of Population Health, under the leadership of Rory Collins and Richard Peto. And I applied for that position and went there. And again, you had to start from the beginning. Again, it was quite interesting, where as a clinician, you sometimes don't understand the language of what statisticians and epidemiologists are talking about. So I had to again step back and take an MSc in epidemiology and public health at London School of Hygiene and Tropical Medicine to just learn the basics fundamentally. But it was also the interaction with the really great people who came on a weekly basis, gave seminars from all over the world, that created really the interest in me on doing epidemiology and clinical trials. And then after that period, a few years, I was still torn between the fast-paced cardiology activities where you get immediate rewards and immediate rejections probably, and the sort of a somewhat more slow-paced epidemiology and clinical trials where the rewards are not coming immediately. You have to work for a few years. So I decided to just spend more time on clinical trials and epidemiology. So that, none of that involved, obviously, the BPLTTC. So in parallel to that, some of the other great people, Stephen McMahon, John Chalmers, Bruce Neal, have been working on the blood pressure lowering treatment trialist collaboration in Sydney, Australia. And that has been going on for several years. I mean, the first publication came, I think, out in 1998. And at that time, when Stephen McMahon was establishing a unit in Oxford, I was keen to just work with him. And that was really a sort of a chance that I got exposed to BPLTTC, having been previously with Colin Bajan and others familiar with the CTT, the cholesterol trialist collaboration. I saw an opportunity and passion to just do something about this. And the starting point here was that, at that time, a lot has happened in blood pressure space, and the scale of BPLTTC had somewhat diminished. So this is essentially just wrapping up how I got to the BPLTTC. It really has more to do to chance, but building up really on the work of some of the legends in that field and taking over the baton from them.
That's a fantastic journey. And we, as a group of, looking at the papers you produced this year, we were particularly interested, of course, in the blood pressure issues. And maybe I'll switch to Carlo because I'm sure he is an expert of analysis of data, and he wants to maybe introduce some question to you for, and of course we expect many questions from all the participants if possible. And so Carlo.
Yes. Well, Kazem, you already mentioned Richard Pito, Rory Collins, and Colin Bagent. And so I would like to put the BPLTTC within the context of similar collaborative efforts by other Oxford investigators. And perhaps here your views on the general philosophical and scientific approach that you and your colleagues have developed to the aim of promoting cardiovascular prevention.
Yes, absolutely. I mean, probably, Richard Pito, and many have mentioned it, has had the greatest influence on understanding and promoting the idea that many healthcare interventions, in particular in the context of multi-cause conditions, will have only modest effect on outcomes of interest, clinical outcomes. And in order to be able to detect that outcome, you end up having to conduct large-scale studies. Otherwise, you might miss the effect. And that, is of course a history behind that, and many are familiar with the large-scale trials, ISIS trials starting in Oxford and so on. And as you've mentioned, subsequently the whole methods behind meta-analysis. No matter how large the trials are, sometimes they cannot answer the questions themselves conclusively. And the idea was, if you pool information from several trials, you can get more reliable information. And that was really the idea behind BPLTTC. So we know, of course, that on average, reducing blood pressure is a good thing. But then the key questions are in whom, when, what kind of outcomes does it impact? Mm-hmm. Are there any differences? And those type of questions require substantially larger sample sizes than any individual clinical trial can collect typically. And so this is essentially the idea behind BPLTTC, conducting meta-analysis. And for those who are not familiar with it, I mean, there are of course different types of meta-analysis. One is a simple one that you just extract published information and summarize them. I think they provide useful information. But what BPLTTC is individual participant data meta-analysis, which means you bring the data set from different trials together to analyze treatment effects. There are different ways of doing it. And what we started doing in BPLTTC when I took over in, I think around 2014, was to move towards a so-called one-stage IPD meta-analysis. And what it means, you essentially create a single database of all trials that you can get your hands on, and trying to harmonize really the information across them. And that becomes incredibly powerful. You can analyze several trials as a single trial and look for interactions and multiple interactions that we in the current era are so much interested. Many clinicians talk about, personalized medicine, precision medicine. And the statistical way of going about it is to just do very large studies and then stratify to just see whether there is any heterogeneity of treatment effects. So that is really the philosophy between BPLTTC, and that builds on the thinking that Richard Pito, and subsequently Rory Collins and others have really seeded in my mind.
Thank you, Kazem. Massimo.
Franz, thank you very much for accepting to be with us. What is your feeling about the IPD meta-analysis on blood pressure? I'm sure you've gone through the latest studies, and what is your opinion, if you have a question for Kazem?
Thanks so much, Massimo. Now, my dictum about the meta-analysis. The meta-analysis is like a bouillabaisse. No matter how much fresh seafood is added, one rotten fish will make it stink. So having said this, of course, I want to make it very clear, this is an outstanding, well done meta-analysis. Nevertheless, if I dare to be a little bit sarcastic and bring up a dictum from the US, And that is, what is the indication for a chiropractor? Well, the indication for a chiropractor is when you have a spine. And now we can very simply say, what's the indication for an antihypertensive? Well, according to the BPLTT study, the indication for an antihypertensive is when you have a blood pressure, right? And therefore, it is, as I said, this is a little bit sarcastic, but this brings up a simple question. And that is, at the time when we used to define hypertension, it was actually one good thing. You could tell occasionally a patient, no, sir, no, ma'am, you do not have high blood pressure. You don't need antihypertensive medication. And my question to Kazem is now, is there still a person who can go through life at no risk of having a stroke or a heart attack without ever taking a blood pressure pill?
So if I understood your question, you're just saying an individual being labeled to have hypertension, whether that person go through life without getting any antihypertensives and not suffering a cardiovascular event. Is that what you asked?
Well, basically, yes. Is there such an individual after the BPLTT study?
Yeah, no, yeah, absolutely. And I think you're going in the direction to just say whether everyone needs a treatment. Definitely not. I mean, if you look at statistics of it, even if someone is predicted to have a cardiovascular event, let's say the predicted probability of someone having a cardiovascular event in the next 10 years is 20%, that would be deemed to be a high risk. If you look at what is the positive predictive value, I mean, among those who have been classified to be high risk, how many of them will actually end up having a cardiovascular event? It is about 25%, which means even without treatment, a vast majority of people deemed to be high risk will not suffer an event. That is the reality of it. But that doesn't mean that people should not be treated. I mean, we can discuss that when what should be the threshold set for it. But this is not, and it should not be the message from the BPLTTC that if you have a blood pressure, you should get an antihypertensive. This would be a misinterpretation of the evidence.
Well, yeah, I think this focus fully, but allow me to challenge you a little bit more. Lisinopril is right now the most commonly antihypertensive drug used worldwide. In the US, more than 100 million prescriptions per year. Now, one side effect of lisinopril is angioedema, which can be fatal. Remember that in the ALLHAT study, one patient died. In the HOPE study, one patient died of angioedema. We can calculate that with the current use of lisinopril, there are a few hundred people who die every year just because of antihypertensive medicine. Yeah. Now, my question, given the data of BPLTT, should antihypertensive drugs be available over the counter without a prescription? Because practically everybody will need it more sooner or later, right?
I don't think that everyone will need it. I mean, the question is what is the goal of a health system and what are the priorities of an individual? And I think what BPLTT provides is really the evidence. What are the consequences of the choices that pressure is 150 50 millimeter mercury, and let's say moderate risk of cardiovascular disease, what are the consequences of taking a ramipril or not taking the ramipril? Ultimately, it would be the choice of the health system to decide whether this is a cost-effective solution for improving health of the citizens and, of course, an individual to take it. The way I see it is like any other preventive treatment, there are trade-offs. That, by the way, when I say intervention and treatment, I'm not referring just to drug treatment. I mean, if you look at lifestyle interventions, they also incur costs and have their own consequences. So when it comes to those, we have to just look at them about what do we gain from them? by comparison of not taking them. And being in clinic, I mean, a lot of people ask me the question about should I be taking that statin or not? I mean, you could extend that question really to many of those preventive therapies. And the response is, in my view, we should look at them as an insurance policy. If you've got a house, the probability of your house getting burned in a storm or a fire is minimal. Still, you're likely to have a home insurance. So that is the reality of it. Over long term, the study after study has shown that the net benefit is going to be greater than the net harm.
Well, after the Swiss cookies, now we have the Spanish tapas, and I'm not sure they will be sweeter. Luis, thank you.
The Spanish tapas are not sweet, salty, and can be hot. And this is it's a pleasure to be here, Kazem, and I think I have followed all the papers that you have published. So I have a few questions. And the first one should be, I mean, you consider of great relevance cardiovascular risk and then blood pressure. So maybe global risk is more important than blood pressure. And so if you take a look at the many studies that you have included in your many published paper, in your opinion, the control of associated cardiovascular risk, in trials of hypertension has been improving with time, or has it remained in a similar situation? Because this could be very important, I mean, for the outcome.
Let me just rephrase your question so that I can make sure that I understand it correctly. So what you're saying is that the background treatment has changed over time, and that begs the question whether the findings of BPLTT are relevant today. Is that your question?
No. The idea is that the control of accompanying risk factors in hypertension, has improved with time.
Yeah.
Or it remains in some way incorrect. So it's not as good as it must be. Because then, I mean, the other factors could be important for the outcome of the patients, even controlling blood pressure.
Yeah, okay. So your question is about the patterns of change in blood pressure themselves over time, right?
Yeah.
Yeah, good question. I mean, my friend and colleague, one of the other people that I've learned a lot from, Majid Ezzati, who leads the NCD risk collaboration, has gathered excellent data on patterns of blood pressure trends over time. And what we see is, yes, there has been a decline, in particular in high-income countries, where the average population blood pressure has gone down. We have seen, unfortunately, a stagnation of those blood pressure levels in high-income countries over the past 10 or 15 years. And of course, we are seeing a rise in low and middle-income countries. So this is the pattern that we see. But even in some of the top countries, and some of the top countries, if you look at it, the age-standardized blood pressure in South Korea is reported to be around 115 millimeter mercury systolic. I think this is remarkable, what essentially has been achieved over time. But there are many countries, including many European countries, where the age-standardized blood pressure remains in the order of 135, 140, which means there are a number of people who are above even the conventional thresholds of hypertension, despite all the research that we have done, and we have not managed to curb that. And the story since COVID, there are studies coming out that shows, unfortunately, a lot of the achievements that we have managed to obtain over the past few years seems to have, just over the short period of COVID-19, have vanished. And that is in particular in relation to blood pressure control and management.
Yeah. And in your opinion, do you think that we need one or maybe more trials in which out-of-office blood pressure is considered as the objective of those trials, and that this will clarify more the control of blood pressure?
So if you look at the research that we have done, and this is just my personal opinion, what we see is, as the recent BPLTT papers have shown, that an individual's blood pressure is not an important factor in predicting how much benefit they will gain from using antihypertensive drugs. And what we have also seen, this is not the work done by us, by colleagues, Bruce Neal and others, is that at the level of an individual, it's actually incredibly hard to predict the response to antihypertensive treatment. So let's say you've got an individual who comes to clinic and their blood pressure is 155. You give them some treatment and then you bring them back a few months later to just see what has been doing. You could replace that with ambulatory blood pressure monitoring and so on. The reality is that the measurement noise and the variability at the level of an individual that is unrelated to the drug is by orders of magnitude higher than the effect that we're going to see from the drug. Because the trial evidence, and we have done it in BPLC, is quite clear. For one class of drug, on average, in long-term clinical trials, we have roughly seen a blood pressure reduction in the order of 5 millimeter mercury systolic. For more intensive treatment regimens, we get it up to 12 to maybe to 15. So this is what we would expect. But if you measure it at the level of individuals, a lot of the time you're confused because you don't know, have they not responded to treatment? Has the blood pressure gone up really? Or is it just noise? Or what is going on? So therefore, my personal opinion is that once cardiovascular risk has been established and we have decided that an individual will benefit from blood pressure lowering treatment, then focusing on measurement subsequently, in my view, does not add much value. But this is, just my personal view.
Because there's been a lot of, debate over the last years on the difference in the US and European guidelines in thresholds to start treatment or targets to reach. And those were mostly based on the interventional trials or prospective trials. And in US, there was this, analysis of the sprint, which was dissected in many ways and brought down the blood pressure thresholds and targets. And in Europe, we were a little bit more conservative. But at this point, my question is, should we revise the way we do the guidelines for hypertension, looking at the enormous amount of data that you have analyzed based on the individual participant data, basically? Is this replacing the way we have been thinking to guidelines and especially to the targets to achieve? Do you think there should be more space for this analytical way to define risk in hypertension? And if this is the case, this is the second question, should be looking at blood pressure like we have been doing with the cholesterol, so just a risk factor with a continuous impact on the cardiovascular risk, and so looking at the antihypertensive treatment as a preventive strategy, which is independent from the thresholds which we've been linked for years. Yeah.
Great questions. On the first one, it's of course not up to me to decide how guideline committees will make decision. But the way I see it is that, we have been doing an excellent job for writing, the ESC guidelines. I was not involved in it. Those who have done the hard work, the American guidelines and so on. But there was a gray zone. Some of the information that the experts required to make decision was not available. And of course, we know it as clinicians. Decisions have to be made. We cannot defer them until perfect evidence emerges. But I think we have now got the analytical tools, as you just said, and some of the evidence that will fill the gap in some of those guidelines. And in my view, the direction of the journey would be towards simplification. So, I don't know how you feel, but, I personally, maybe I struggle a bit sometimes when I go through these guidelines. I get a bit lost about what is now the threshold, in which person should I do what, and that becomes very, very complicated. And I think that the recent studies by BPLTT should help simplify that. And that goes exactly to the second part of your question, in the direction that we have been going with cholesterol, thinking as a single risk factor, but the purpose of lowering cholesterol is to prevent cardiovascular events, not lowering cholesterol. And I think in a similar way, we should start thinking about blood pressure lowering, blood pressure being a risk factor, but the purpose of using interventions to reduce blood pressure is to prevent cardiovascular events. Now, of course, there is, if you like, some controversy around this. Can we see blood pressure in the same way as we have seen cholesterol? Speaking to many, including some of the epidemiologists, there is, of course, the perception or the idea that unlike cholesterol, where we can, let's say, if we could practically bring it down to almost zero without any problem, with blood pressure, we can't do that. Of course, we need blood pressure to be able to perform our daily activities, right? Blood pressure zero equals death. But this is not what the BPLTT says. I mean, there is still a physiological range. When I went to medical school, there was the perception that, of course, anything above 140, and that is still the paradigm, is not a good thing. But, as you know, a few decades ago, the threshold was at 200. People felt, this is a natural process of aging, and we should not treat anything that is below 200. And it's interesting, if you look at what is the normal blood pressure, there are good studies that have been done in populations that are not exposed to our industrialized lifestyle. Two interesting insights comes from that. One is that, the average population level in those regions tend to be around 95 systolic to 105 millimeter mercury systolic. That is one important insight. The second thing is that blood pressure does not increase with age. So accepting the rise in blood pressure with age is just natural, is not supported by those studies. And in fact, as I said earlier, those ecological studies are sometimes a bit undervalued, but I quite like them as someone who's interested in epidemiology. If you compare different countries and you realize that in one country, the blood pressure is in the order of 115 and the other one is 150, you realize there must be reasons behind it that suggest that blood pressure could be lowered to that level. So whilst accepting that, blood pressure, a certain level of blood pressure required for us to have a healthy lifestyle, I don't think that, the thresholds that we have been clinically looking at are nowhere near those. And this is supported to some extent by BPLTT in interventional studies.
But there are many questions popping up. So if you can keep the answers short to we give the audience the possibility to. But the first is from Dr. Merpod Bashkut. Thanks for this nice webinar. Professor Rahimi, it's a great pleasure to be here. Just want to ask, what is, in your opinion, the use of new analytic methods, including artificial intelligence or machine learning, to moving further and individualize hypertension treatment for each person? Now have a very good and reliable data, and it seems that using some machine learning methods might be a good idea in your highly valuable trial. So what do you think?
I lead the deep medicine lab in Oxford, and I'm a big supporter of innovative ways of analyzing data. In the context of blood pressure management, as I said before, in order for us to show that there is any heterogeneity of treatment effects, we would need to have large data sets. And for machine learning models, for them to perform really well, to be able to separate the groups differently, we don't need large data, we also need deep data. Unfortunately, clinical trials don't provide that level of detailed information for us to be able to do that stratification within a randomized setting. But I think it's an interesting research area that should be pursued. Where I do see an opportunity, and that is where some of our thinking is going, is in the context of risk prediction? I keep it short to just enable other people to answer, but I think there is a room for replacing the conventional risk prediction models for better models and guiding decision-making, but not for heterogeneity of treatment effects yet.
Well, I have a question from George Bakris, but I can see him. So if you want to ask directly the question, George.
Okay, very good. So this is a great interaction here. I'm on a very practical issue because, first of all, let me just tell you, as a guideline writer, I range of blood pressures rather than one number, because I think that's much more close to the truth. So if you're anywhere between 120 and 135, you should be in great shape. I think a notion of one number is crazy. That's not physiology, it's physics, and that's not how we behave. Your perspective on this. Obesity is out of control internationally. Obesity is leading to diabetes, leading to kidney disease internationally. Where I'm going with this is that we all know if you have any level of kidney disease, your blood pressure control is going to be far more difficult and much more likely to be at higher levels. So wouldn't it be better? And we know the effect of sodium. That's a given. I've seen situations of patients referred to me that have been on triple 4-drug therapy, and simply by adhering to a strict low sodium diet over the span of 2 months, they've come off all their therapy, all of it. Their blood pressures are great, their kidney function's normal, and all this. Now that's, individual. But if we had a governmental policy to restrict the amount of sodium in most restaurants, or to pay an extra tax on obesity, what do you think would happen with blood pressure control rates? I think by default, better. So I'm asking a political question, but I'm giving you some reference as to where I'm coming from too.
Keep it short.
Yeah.
I'm sorry, Massimo. I'm sorry.
First of all, great, George, for having you here and raising that question. I completely agree with you. I mean, you're well familiar with the great study that Bruce Neal and colleagues did, the SAS trial, looking at sodium replacement therapy, salt substitute. And that showed, an impact similar to the drug effect. I mean, that is remarkable. But if you look at, if I recall correctly, the level of blood pressure reduction with salt substitute in the trial was in the order of 3-4 millimeter mercury systolic. And this is what we would see, and that would be huge at the level of a population to have. So, I mean, I think probably, as you've just said, your anecdote of individual patient that, that extreme change might not be replicable. But I think it is important for us to just apply those. And the point that, I would also like to make, I think those interventions are complementary. When we talk about blood pressure reduction, it should not be about drugs only. It is about, all tools that we have at public policy, at behavioral, at nutritional, as well as drugs or maybe devices.
There's a question from Professor Kennedy Cruikshank. I'm not sure you can answer this, but it's important to introduce another concept. Given the noise to signal ratio for an individual, isn't time we intervene in big trials on top of blood pressure on the arteries directly, for instance, targeting pulse wave velocity? That's
So, I mean, one way of trying to reduce the effect of measurement noise is, as people just saying, use other technologies. This could be pulse rate velocity. This could be essentially direct measurements. Could be repeated measurements over time to get rid of that. I think all of those are useful. But in my view, the far better approach is measuring cardiovascular risk. Because what would happen if you combine a number of risk factors into a statistical model? The level of a contribution that any of those individually makes gets essentially less relevant. And we have done some studies in that context if you replace in a statistical model a one-off measurement of the blood pressure, which is very noisy, with a measure of the blood pressure that takes into account regression to the mean, the long-term changes in blood pressure, taking account even 12 years of individual's blood pressure measurement, the performance, the discriminative performance of the model, the C statistics hardly changes. So that is yet another point of moving towards risk-based selection of individuals for treatment. I'm not dismissing the value of more reliable measurement of blood pressure, but when it comes to selection of the patients, I believe those multivariable risk models are a better solution.
Because then there's I saw an hand raised from Bruno Trimarco. I don't see him, but Bruno, if you want to ask your question.
A very short question. What is your idea about the new concept of time on target blood pressure? At what extent it may modify the management or the epidemiology of hypertension?
Yeah, that is very, very interesting question. I don't have the full answer. I mean, that is one of the projects that we would like to just embark on in BPLC in due course. But to just reframe it perhaps for the audience, as I understand it, the question is there a cumulative effect of blood pressure reduction, or in fact, is the cumulative effect of long-term blood pressure on cardiovascular outcomes? Because if that is the case, then of course, we would be able to make a better case for treating even lower risk people earlier for longer duration. So I think it's interesting, and it requires further research, but to my knowledge, in the context of blood pressure interventional studies, there is no evidence to suggest that treating an individual over 1 year or 3 years or 5 years will lead to a compounding effect of the relative effects.
Yeah, there's a question from Olivia Manfrini, whether sex should be considered as a biological variable in the treatment of hypertension. Definitely you have data on the gender influence on your analysis.
On that one, I just say watch the space, and the sex stratified analysis of BPLTTC are being finalized.
Yeah, well, any question from our panel, from Franz, Luis, and Carlo, and maybe Filippo, if you have any question?
Well, maybe I can ask Kazem, given his privileged position in Oxford, where we have the anti-thrombotic Trialists collaboration, we have the blood cholesterol lowering treatment Trialists collaboration, and your own. Have you tried to look at how early do we see a benefit of these different interventions that aim at reducing cardiovascular risk? That's one aspect of the question. The second is, how do you deal with time-dependent loss of compliance in these long-term trials?
Yes. So let me just answer your second part of your question. That is easier. I mean, of course, when we just measure a treatment effect within clinical trials or within meta-analysis of clinical trials, that already includes the loss of compliance over time. So in fact, that is an important message for patients to realize. The estimate that we are getting is not reflective of full adherence. That is reflective of the average adherence in those clinical trials. And as we know in those clinical trials, as you've just said, the adherence tends to wane over time. Not only that, there is also dropping, because many people would get treatment given that they have to be in the control arm, and we have published some information on that one previously on BPLTTC. So that goes in this in terms of the clinical trials. Now, your question is about the effect
of appearance of the benefit with different interventions.
Yeah, so that is, when there are two components to this. One is in the context of the blood pressure, when is about the outcomes, because you could have a latency period of effect that affects, let's say, myocardial infarction, but not stroke, or it could affect dementia, but not stroke or cancer, and so on. So, there is, we have to, one source of evidence cannot answer all questions. So in this context, we have to actually draw on our sort of biological understanding of how intervention could work. Does it make sense that there is a latency period? As you know, probably, as the audience here knows, in the context of a statin, we have got good evidence to suggest that there seems to be a latency period. The effect are the relative risk reductions are weaker in the first 6 months to a year and tend to sort of gradually pick up. And that might make sense. It might take some time to lead to stabilization of the plaques and prevent atherosclerotic heart disease or vascular disease in general. In the context of blood pressure, we have not done that analysis specifically and would be interesting to do it. But looking at the Kaplan-Meier curves, because we have got time to event data in the one-stage meta-analysis, I don't see this to be the case. The risk curves tend to separate quite early on. And what we haven't included in the blood pressure lowering trials collaboration, of course, the short-term trials, and there are great work done by many others, Craig Anderson in the stroke setting, acute stroke blood pressure reduction, and they show very early effects in that setting. So I'm not sure that there is a latency, but I've said one needs to break it down according to what outcomes one looks at. And the value of that, I think, is if there is no latency period for the outcomes, then we could just decide we just switch on and treat on and off treatment to the periods that an individual is exposed to the greatest risk. But if there has to be a long-term treatment, then of course the equation changes. So I think that are sort of some nuances of decision-making that hopefully we can resolve over time with your help.
Okay. A quick question from UK, from John Cleland, whether NT-proBNP could be the best marker of risk in hypertension. What do you think, and if you have any idea on that?
Yeah, I love John's comments. He brings it always back to heart failure.
Okay.
John, my guess is if one had NT-proBNP and would add it to the sort of the risk models, they would have a huge impact on prediction. And as you know, one of the differences, and people tend to forget, we tend to just, yes, you're right, not just heart failure, I'm just saying the common. One difference between statins and blood pressure lowering is that statins have got no material impact on heart failure incidence, but blood pressure, one of the biggest impact is on preventing heart failure or its deterioration. But I don't know, John, whether we would have enough data in the general population to just see NT-proBNP making an important impact for risk discrimination in those populations. I recall that some studies were done previously in the statin studies, and it helped to some extent. But the thing is with these multivariable risk models, using standard statistical models, as you know, even if you've got a perfect causal risk factor, adding it to 10 other factors that you have, the discrimination doesn't change much.
Franz?
Well, I just see the question here regarding should not everybody get potassium? And the study by Bruce Neal was exceedingly well done, published in the New England Journal of Medicine, but this was done in a Chinese population that was potassium deficient. No question when a population is potassium deficient, when you give potassium, it has benefits. But in most westernized populations, they are potassium replete. So giving potassium will have little, if any, effect. If you don't believe me, please read my editorial. Filippo will tell you when it's coming out, probably in a week or two.
So I'm not sure whether it was an interesting comment, but I can't actually answer that. I mean, my view is that the study that Bruce and others did, of course, they had to do it in a setting where you could do the intervention, and that happened to be in the Chinese setting. I don't think actually doing it in a different country, everything else being equal, would have made a difference. The point about potassium is a good one, but again, I don't think that one should look at one single study to inform all decisions, and I don't think that is what the SAS trial or Bruce Neal have done. There have been other studies that essentially support that finding. There is still the uncertainty: is it the potassium or is it the sodium? I know, and I think the answer is probably both.
I can see Giuseppe Mancia here, and Giuseppe has participated in several sets of guidelines, and you've been following the discussion today. And should this meta-analysis in IPD data have more space for performing the risk analysis and setting the thresholds in the future guidelines? What do you think? Or if you want to ask a question to Kazem.
Yes, I can. Thank you very much. Unfortunately, I joined later, so I haven't seen the first part of this very interesting meeting. Yes, my question is, the lower the better is a very attractive concept. But in the end, if we follow Kazem data, maybe we should follow these data in clinical practice. I think everybody is a candidate for treatment. Now, Kazem said not necessarily drug treatment, and could be lifestyle changes. But even those with a blood pressure below 120 millimeter of mercury should be thinking of lowering blood pressure. And this seems a bit difficult to me to accept. But of course, I may be wrong. If I can add one other thing, Massimo, this refers to the very important question asked by Bruno Trimarco. That is the concept of the time on blood pressure control. This is not really a new concept. It's a new approach, but the concept is old. And there were data, post-hoc analysis of invest, on target and value, showing that independently on the mean blood pressure during the treatment period, the number of visits in which blood pressure achieved control is related to cardiovascular outcomes. And the time to target is calculated by the number of visits in which blood pressure is controlled, because of course we do not have continuous blood pressure assessment. So I think this is something to be explored in the future, and maybe individual data analysis can have a chance, in individual-based meta-analysis have a chance to look at this.
Kazem? Kazem?
Yeah, absolutely. I think has a chance, and we should look into it in the future. On your I don't know if you would like me to comment on your first statement about thresholds and treatment, because it was just a statement, not a question, and is up to the chairs.
Oh, I think it's just a comment. Also, another thing which I wonder is, in many studies, we have seen that lowering blood pressure below a certain value is associated with an increase in the risk of events. Now, the interpretation of these data is difficult. It could be higher risk at the beginning of these patients, or it could be excessive blood pressure reduction. I mean, in post-hoc data, it is impossible to answer this question, but the increase in risk was there. These were patients in which at the lower blood pressure, the risk was increased.
Okay. No, absolutely. I mean, but I think we should really separate observational data from randomized evidence. As you've just, Giuseppe, I've been learning a lot from you and your wisdom. When it comes to observational data, we know that some people at a sort of a lower blood pressure threshold are at higher risk. Many of them might have incipient heart failure. They're going in that range where the risk of cardiovascular endpoints is very high. But that does not equal the message that they should not be treated. In fact, there are parallels to heart failure. As you know, many of the agents, the antihypertensive drugs that we use, are the same that we use in people with heart failure. Despite the fact that the blood pressure is very low, they still gain a huge benefit from it. So the point on BPLC and what we found is not that we should bring down everyone's blood pressure down to, I don't know, 115. That is not that. I mean, that's not what it shows. The point is, let's just imagine two individuals. being similar with every respect. The predicted cardiovascular risk is the same. And one individual, the blood pressure is 150, the other one blood pressure is 120. So what are the consequences of lowering blood pressure by 10 millimeter mercury in each of them? What BPLC shows, the effect on cardiovascular outcomes is going to be the same. And that means that it just essentially challenges to think, why should we withhold a treatment that could prevent a vast number of cardiovascular events? Because in our mind, we have got a threshold that we know actually doesn't make sense. That is why we keep changing it in different people. And again, if you look at global numbers, the statistics are compelling. You know, if you look at global burden of disease, the work that NCD Risk has done, the attributable risk to elevated blood pressure defined as anything above 115, what we have estimated is, in the past 2 years, 10 million premature deaths every year. That is, goes to that. If you split that, about 3 million of them are among people whose blood pressure is less than 140. And
we have only 5 minutes left, but I see a hand raised by Susana San Menendez. Susana, you here?
Yes. Can you hear me?
Yeah, sure.
Yeah. I wanted to ask, how confident are you about the precision of the modern devices on blood pressure measurement as compared with the mercury sphygmomanometers? In measuring treatment effects of small differences, this might matter a lot. And the question is, are we sufficiently confident about the new modern devices of blood pressure measurement?
Quick answer, Kazem.
Yeah, actually, I don't have an answer on that one. It's not an area of my expertise. I have to pass that one.
Yeah, it's Professor Kennedy. You want to ask your question? I can read it, but I know that you want to ask a question. Please.
Thanks very much. I don't know, in the last 5 minutes, can you hear me?
Yeah, sure.
Whether you really want to, but just to take you up on your statistical model versus more direct action. I think one of the consequences, if we're dealing with this as a debate and how to take it to the future, is we need evidence of the sort that you've spent your career pulling together. And it slightly stifles other types of clinical trial. In Britain, for instance, despite its current government's approach, getting money to do a study where you want to look at arterial function, adding to interventions on arterial function, adding to benefit from blood pressure reduction. We've at last had one big trial from France showing its benefit. But there's a sort of intellectual complacency, dare I say, that we're doing all right, thanks. We don't need any more, as you've sort of hinted with the other risk factors.
Okay, Kazem.
You know, I did not try to imply that we don't need more research. You know, I'm a researcher and I'm in favor of more research, and I struggle, like you described, with getting funding. And I'm actually glad that you bring that up, because sometimes, you know, a few years ago when we went to funding bodies trying to get some funding for BPLTT, that was rejected several times. People felt we have got all the answers. So, you know, this is a battle that all of us have gone through, and this is my daily life of getting rejection one after the other. But, you know, I think if the questions are important, we will get there eventually.
Yeah, I don't see any further question from Luis. Filippo is raised then, our editor. Filippo.
Well, I thoroughly enjoyed this wonderful debate, very instructive and interesting, and with a lot of participation. I had, Kazem, for you, perhaps a last broad question. Is about risk factors patients cannot change. This was the title of an editorial I published some months ago. Risk factors patients cannot change because we need population level interventions. Now, my question is about the following topics. Well, sodium, what is your suggestion regarding the intervention at population level. Second, potassium. Third, pollution, which is not just air pollution. We also have danger coming from noise pollution and light pollution. I think that these are 5 interesting topics also for hypertension. Now, what is your priority among these 5 interventions? Sodium, potassium, and pollution. What is the priority? What do you think is more important in order to reduce the risk of hypertension at population level? And thank you again to you and all other colleagues for this really wonderful debate, wonderful dialogue.
So Filippo, great question. I mean, again, like as I've said before, for me, is not one versus the other. But what you've just said, many of those environmental lifestyle risk factors are hugely important, and unfortunately, they're somewhat out of the control of an individual. And as physicians, we've got, we could advise people to change their lifestyle, but until the environment is changed, until the policy is changed, very little will happen. My understanding is from those that you listed, as we discussed earlier, there's a bit of an uncertainty, sodium and potassium, whether they're independent or work together. I think this will by far have the greatest impact if we get the policies right. I know many people are working in that area. I mean, there are hopefully people here who can influence that. In Western societies, most of our food comes from processed food. So we have got actually very little control on changing it. And that needs to be dealt with in a multi-sectoral way. It is going to be hugely challenging. The role of noise and air pollution is emerging. To what extent, the quantification of it will play a role is still, I think, topic of research, but we know it will have huge advantages on a number of fronts, not just cardiovascular disease. And many of those environmental factors tend to interact. So, I mean, I'm not, I have to leave it, unfortunately, at that vague level and just give you my opinion about the importance of them. I think they're all important.
It was a privilege for me to run this dialogue. The hour went very fast, and thank you very much, Kazem, for being with us. But I would like to switch to Carlo for maybe a closing remark on this wonderful afternoon. Thank you very much again from my side.
Yeah, it's always unpleasant to end such an interesting and stimulating discussion, but we had decided to set a limit to 1 hour dialogue, and we want to adhere to this principle. So first of all, thank you very much, Kazem, for a very stimulating and refreshing outlook at a problem that has been a source of interest and study of many people who attended this dialogue. I think the work that you have done is fundamental and will certainly lead to new avenues in terms of the way we look at blood pressure. Thank you, Professor Messerli. Thank you, Professor Volpe, for contributing through stimulating questions and comments. Thank you, Massimo, for leading this dialogue with great experience and balance. And last but not least, thank you, Professor Crea, for hosting this dialogue, for this brilliant idea of these monthly forums. And thank you all for participating actively in the whole discussion. And bye.
Yeah, if I can make a last announcement, thank you for your kind words. And the dialogue definitely is a link between the journal and our readers, authors, and reviewers. And I think it is important really to have this link, because we all work together with the same goal. I want just to announce next dialogue, which will be on May 26th, as usual, the last Thursday of the month at 5 p.m. CET. And the next dialogue will be with Professor Karen Sligua. She is professor of cardiology in Cape Town, and she's one of the leaders, so the leader of cardiology in Africa. So it will be a very interesting dialogue on the role of women in cardiology, on the problems of cardiology in Africa, and I'm sure will be very, very entertaining. I think that we should have our we should keep our perspective global. And in the globe, we have 5 continents, and the next continent, which will be the protagonist of the dialogue, will be Africa with Professor Karen Sligua. And of course, we all invited to our next dialogues and to those which will follow. Thank you.
Great.
Bye-bye all.
Thank you.
Thank you all.
Thank you everyone for joining then, and we'll just wait for everybody to sign off.
Yeah, Kazem, that was great. Yeah.
Yeah, I mean, that was, I really enjoyed that. You